Well, thank you, Mr. Chairman, and thank you for allowing me to wave on to the Health Subcommittee, which I'm not currently a member of. And thank you to all the witnesses who spent a lot of your time today talking about issues that are important to you, but also important to us. I want to particularly welcome Dr. Richardson to our committee, who's from Wichita, and I've been to their facility there, and appreciate the opportunity to see the day-to-day activities. As you noted, Dr. Richardson, your practice doesn't just serve patients in Wichita, but across the state of Kansas and into Oklahoma. And also, across the country, physicians like you are serving rural Americans, providing quality health care in parts of our country that are too small to support specialists on their own. Unfortunately, we're seeing bureaucratic red tape, lower reimbursement rates, rising prices are all weighing heavily on your independent physician practices, and we're seeing those private practices close or consolidate as a result. Mr. Chairman, I have a letter that Dr. Winstrup gave me from a primary care physician who talked about being an independent physician versus being a hospital employee, and I'd like to submit that for the record. And
without objection.
Thank you. As I've spoken with patients and physicians and support staff throughout Kansas, consolidating or closing practices is not helping Kansans receive more or better quality care. With fewer and fewer doctors and nurses in private practice, patients are seeing increased costs and in some cases worse outcomes. The Kellogg School of Management notes that prices increased 14% when a private practice is acquired by a hospital, and a National Opinion Research Center survey found that 45% of physicians report deteriorating patient-provider relationships after consolidation. These increased costs and diminished outcomes are not the recipe for a healthy society, and our committee must prioritize solutions that preserve the vital role of private practices. Dr. Richardson, I'm especially intrigued by your practice because you've been able to stay independent while serving more than 1 million patients throughout rural parts of our state. In your testimony, you highlighted the fact that Wichita Urology has managed to remain independent, in part because of the shortage of urologists in Kansas. Unfortunately, urology is far from the only specialty with a physician shortage in Kansas, which, as you know, often impacts most importantly the rural parts of our state. Can you elaborate on how your private practice is still open to serve these rural areas and how that is not often an option for physician groups that have been acquired?
Yes, thank you. Thank you for being here, and nice to see you. Yeah, we're not unique in the specialty in our area that does these outreach clinics. Gastroenterology, cardiology, rheumatology, a lot of the specialists do the same outreach clinics throughout rural Kansas because they know it's needed, because they know that those patients can't drive 3 to 4 hours, and those patients don't often have any specialists in those areas. Speaking on consolidation, there is a hospital system that does own specialists that do no outreach, right? So that's the picture of consolidation in our area. The independent physicians are reaching out, doing telemedicine, driving, having clinics at these rural communities to reach those rural patients, while the consolidated hospital system is not. They're allowing those patients to drive. You also mentioned the increased cost of running a medical practice, the inflation. It's that reason only that we have considered consolidating ourselves back to Wichita and taking our staff out of those outreach clinics. It's not because we don't enjoy seeing those patients in the rural areas. It's not because those rural patients don't need it. It's because we almost can't afford it with the difficulty in hiring new nurses, new MAs, the increased cost of running healthcare. We have talked about, just from a financial standpoint, consolidating. And like I said, we haven't had the heart to do it, and I hope we won't, and I don't think we will. But that's the only reason we've even had that conversation.
Yeah, thank you for that. And I know we have much more importance around the folks that live in Wichita or other urban areas don't realize and they take healthcare for granted because you may have 10 or 20 specialists 10 or 20 minutes away that you can actually interact with. That's not necessarily the case in rural areas. You also mentioned about site-neutral payments and they don't necessarily equalize. Can you provide further details on how policies could be managed without necessarily reducing payments to hospitals?
Yeah, like I said in my opening statement, I don't think the right thing is to just decrease payments to hospitals. That doesn't necessarily help physician practices stay in business. It doesn't help access. It doesn't help the patients. But I do think that it is an unfair, unlevel playing field. Right now, we're competing with those systems for the same providers, the same doctors, the same nurses, the same MAs, which makes it difficult for us to run an independent practice. So I think site neutrality is, if not the most important, one of the top 2 important things of keeping independent physicians in practice. We are simply just competing against someone that we can't beat. And so I think a more reasonable solution would be to modestly have a decrease in the HOPD payment and a modest increase in the physician. No one is asking to just decrease payments for hospitals. That doesn't help our practices stay in business. That doesn't help us serve patients, and it certainly doesn't help increase access.
Well, thank you, and thank you all the panelists again. I yield back, Mr. Chairman.